Thank you, sir. So I'll be just talking about the original ranibizumab that we know, which is so this talk is actually divided into sections in which initially I'll just talk about a breakthrough, like how anti-VEGFs were a breakthrough in the management of retinal diseases almost 20 years back, and how ranibizumab became the gold standard anti-VEGF because of its efficacy. There's a lot of evidence on that. What is the innovator edge? How the patent molecule is supposed to be, the best. The pharmacoeconomics perspective, and what is the key takeaway. So pre-2006, we all know all these patients were turning blind, and there was a marked burden of blindness because of diseases like age-related macular degeneration, because all we had for these conditions was laser, photodynamic therapy and surgical interventions, which were not the perfect treatments for this particular problem, and patients eventually lost vision. Then 2006 was a paradigm shift in the management of retinal diseases, and these were the landmark trials which established that. We all know these trials, and there was an improvement of about 7.2 letters which was seen in Anchor, and about 11.3 letters which was seen in the Marina trial. What has changed since then? So there has been a 46 to 72% reduction in blindness, and these are reports from various countries, where 50%, 51%, 46% and 72% in the United States, based on these studies, where there is a reduction in blindness by that magnitude. With 18 years of extensive experience, the original ranibizumab is the gold standard treatment choice because of its efficacy, because of the innovator edge and the pharmacoeconomics. Original ranibizumab is supported by a large amount of clinical evidence and patient experience. It has the largest number of approved indications. It has the largest number of clinical trials, so 6 approved indications, more than 7 years of long-term data available, more than 22,000 patients included in extensive clinical trials, and more than 73,000 patient years from continued post-marketing real-world data and pharmacovigilance studies. So this has the largest amount of patient data for any of the drugs in retina today. So the wealth of evidence of original ranibizumab in neovascular AMD also came from the View 1, View 2 trials, and also I won't go into the details of these trials, and of course the CAT trial. Also there was the rival study, which concluded that the study found no significant difference between ranibizumab and aflibercept in the development of macular atrophy in neovascular AMD patients, and they achieved similar number of injections, visual acuity and retinal thickness improvements over 24 months using a treat and extend regimen for neovascular AMD. Also we had the trial, the Rise and Ride trial, where ranibizumab showed visual acuity improvement by month 4 and improvements were maintained through 54 months, and Protocol I, in which ranibizumab alone or combined with laser showed visual acuity improvement in month 12 compared with laser alone. Ranibizumab with deferring laser for more than 24 weeks showed better visual acuity outcomes than ranibizumab with prompt laser, and which was maintained through 36 months. And then we had the Restore study, which showed that ranibizumab alone or combined with laser showed significant improvement in BCVA at month 12 compared with laser alone, maintained through 36 months, maintained with fewer ranibizumab injections. Then we also have the Brighter and the Crystal studies. So these also conclusively proved that ranibizumab was the gold standard anti-VEGF. So the wealth of real-world evidence of original ranibizumab is from the Luminous study, which was the largest prospective observational study in medical retina. It was a global 5-year multi-center observational study across all approved indications to evaluate the long-term effectiveness, safety and treatment patterns associated with the ranibizumab 0.5 milligrams in routine clinical practice, with more than 30,000 patients over 42 countries and 488 sites. Ranibizumab showed a consistent visual acuity outcomes across approved indications. In neovascular AMD, there was an improvement of 6.8 to 12.3 mean BCVA gains in ETDRS letters. In DME, 6.8 to 10.3. In BRVO, 14.3 to 18.3 gain in letters. And in CRVO, 12.1 to 16.9 gain in BCVA letters. and in macular CNV 13.8 BCVA gains, and other CNVs 11 ETDRS letters of BCVA gain. So early visual acuity gains with ranibizumab are maintained long term. This was also seen in the studies. So ranibizumab improved functional areas beyond those related to vision alone, and in which we had this quality questionnaire, the NEI, the National Eye Institute VFQ 25 score, where the role difficulty, social functioning, dependency, driving, color vision, peripheral vision, and mental health all showed improvement. So these were the areas beyond vision which were improved. So with extensive experience of 18 years, the original ranibizumab is the gold standard. The innovator edge, so now another point to consider is how similar are biosimilars with innovators? Are biosimilars manufactured right? How stringent is the approval pathway of biosimilars? Are the current biosimilars interchangeable? So if we just go into the manufacturing process, how biologics are produced, it is quite comprehensive and has multiple steps and leading to higher risk of errors, if not done properly. So we have to know whether the biosimilars are being manufactured correctly, because what they do is reverse engineering. So they begin with limited knowledge of the reference product, and after reverse engineering, the DNA sequence is based on the primary protein sequence of the reference drug, which is available in the public domain. How similar are biosimilars with innovators? How stringent is the approval pathway? So we know that the approval of non-innovator biotherapeutics in India is not very stringent. The FDA has adopted a totality of evidence approach to the approval of biosimilars, in which multiple lines of evidence are integrated to determine biosimilarity by the reduction of residual uncertainty. A simpler regulatory pathway in India might result in misses, and this is where clinical studies for approvals are missing, in India, whereas in the in the West, in the FDA and the European agencies, they have much more stringent controls of manufacturing of biosimilars. So is it the same globally? No, there are no fixed guidelines globally regarding their approval. Guidelines are constantly evolving as technology grows. However, fundamentals of the guidelines across the world are the following: analytical studies to demonstrate high biosimilarity, animal studies for toxicity assessment, clinical study to assess safety, efficacy and immunogenicity compared to the reference biologic. There are multiple steps to assess above 3 described points, and each country has a committee which decides the next step of evidence on the basis of the strength of similarity in the previous step. So does a biosimilar need to go through separate approval for each indication? No. It can be approved for all the indications for which the reference biologic is being used, provided analytical, scientific and clinical data of similarity are robust on the tested indications. The third point to consider, which is the third question, is are the current biosimilars interchangeable? So biosimilarity and interchangeability are two things. So in biosimilarity, a biological product that is highly similar with no clinically meaningful differences is a biosimilar. Whereas interchangeability, you have to see whether one biosimilar, if it's being given to a patient and you can give another biosimilar of a different brand, and whether it's interchangeable. So that is where another problem arises, because nowadays we know there is an array of biosimilars available even for ranibizumab. So to consider the cost of comorbidities with neovascular AMD and DME. So neovascular AMD is associated with an increase in age, which is in turn associated with multiple comorbidities. DME is associated with chronic diabetes mellitus, and diabetes we know is associated with hypertension, obesity and high cholesterol as a part of the metabolic syndrome. And management of these associated comorbidities also has economic implications for the patients. Despite high prevalence and detrimental impact on quality of life, many patients cannot access or adhere to treatment. Reasons for not adherence to therapy are excessive treatment visits, difficulty in attending, expense, pain, discomfort, treatment is not beneficial, or other more severe medical conditions. Cost is another critical barrier, where the cost of the drug, the cost of the procedure, cost of diagnosis, cost of travel and stay, cost of attendance, cost of absenteeism. 37.5% of patients with DME do not comply due to non-affordability. In AMD, about 30% patients do not comply, and in our view, about 25.3% patients do not comply due to non-affordability. So sometimes indirect costs can even exceed direct treatment related costs, which include a multitude of things. So cost may also vary across regimens and drug, whether it is being used PRN, treat and extend, monthly injections, 12 weekly dosing. Hence, number of injections, treatment regimen, disease control may also impact cost. Anti-VEGFs have potential to improve visual outcomes. Innovative treatments like anti-VEGFs have the potential to improve visual outcomes. However, in a self-pay market like India, the high cost of anti-VEGFs and lack of insurance coverage are major roadblocks. Insufficient use of recommended injection regimen leads to suboptimal visual outcomes in the real-world scenario. Indian anti-VEGF market is fragmented with innovator, biosimilar and off-label options, and thus creates a dilemma amongst the healthcare providers to choose an apt choice for their patients. There is a need for a cost calculator, considering both direct and indirect costs to facilitate evidence-based decision making. And in the 22nd EURETINA Congress at Hamburg, this cost calculator was described, where it's a tool as simple as Optimize cost calculator, which will facilitate evidence-based decision making in 4 easy steps: patient inputs, molecule inputs, treatment inputs, and then we get the dynamic results for various disease indications. And in that the outcome is out-of-pocket costs we can get easy comparison between various treatments, outcomes after considering PSPs and insurance coverage, and this assists the healthcare providers to facilitate evidence-based decision making. So this is a snapshot of the optimized cost calculator, which is available online. And again, you can see here that with ranibizumab, the cost is coming to about 27,833, whereas for the biosimilar it's about 24,833, and for bevacizumab it is cheaper at 19,500, but of course with the attendant risks of being an off-label drug and the spurious drug, which we saw created a lot of issues in the past. So to conclude, with innovators and originals, there is an optimum risk benefit and lesser short and long-term complications, better anatomical and visual outcomes, and limited difference in the net cost. So therefore, the original ranibizumab, the gold standard anti-VEGF, scores. Innovator ranibizumab has demonstrated a well-established efficacy in RCTs with long-term data in 7 indications over 18 years. And the rapid clinical outcomes with innovator ranibizumab are sustained up to 5 years and are achieved with substantial reduction in injection frequency over time. Interchangeability is a vital quality for biosimilars to possess, which requires additional evidences to prove that the studied molecule produces the same clinical result as the reference product. Standardization and stringency in biosimilars approval process is need of the hour, and plethora of evidence plus high patient offering gives high cost benefit ratio with innovator ranibizumab. So counsel your patients well to make an informed choice. Do it right the first time. We don't always get a second chance. Thank you.
Thank you, Saurabh, for this detailed presentation on ranibizumab. What we'll do is, because there are total of 4 talks. One talk is on ranibizumab. We'll have discussion now, and rest of 3 talks, I'm presuming they are primarily on ranibizumab. So we can have combined discussion on ranibizumab. So, Saurabh, you presented everything in favor of the innovator. So for you in your practice, you don't use biosimilar at all?
No. So I had to incorporate biosimilars because again, some of these things are new, the cost calculator and all. We have not used that to see.
No, the reason I'm asking is, patient in our country will leave everything to you. Patient will ask, Dr. Sahab, meri aankh ke liye kaun sa acha hai? So you advise innovator or biosimilar?
So if there is no financial,
because if you give him options, so he will say, Dr. Sahab, kaun sa aap bata do. Wahi puchte. I don't think the patient will go strictly by the cost only.
So if the patient is affording and there are no financial constraints, and if the patient happens to be a panel patient, or the cost is never a consideration, then of course I would like to go for the patent molecule, because I would like to have my good night's sleep. That is what I tell everyone, you know, I mean.
So biosimilars give you sleepless nights?
No, I mean, in the sense when they started out, we all know that we've had our share of issues with, you know, various, we used to then go after which lot
so
number.
So meaning thereby if it's a VIP, you give original, but if it's a
poor
patient, you give biosimilars?
Not really, sir. So it's all a question of affordability, I think. You know, if the patient is affording, yeah, and can afford, or if the patient...
He can afford anything.
Yes. So I would not think twice. You know, I would just go for the patent molecule, because you see that it's a time-tested, you know, drug, and why would I not want to give him, you know, the patent molecule? I mean, it's a no-brainer, I think.
I agree. The reason I still prefer innovator is not because of these reasons. Why I still prefer, because despite the promise of economics by biosimilars, that has not happened. You see, even today, what I say, old is gold. Apart from safety, which you very rightly said, you know, sleepless nights with biosimilar may be slightly more than innovator, and efficacy, I think they are reasonably good. But the issue was of economics also, because the reason of economics is assuming more importance, because if patient does not come for regular treatment, the efficacy or the treatment effect suffers, because then he will, you know, come SOS or PRM. So here lies our counseling part. With the schemes now which are available with the innovator molecule, if you calculate without this calculator also, it is economical. It is economical. The reason is, although you see biosimilars, the profit margin for the doctor is very high. There is no doubt about it, because the MRP is very high. But forget about those things, about doctor's profitability. The innovator molecule still is gold. Like you say, old is gold. So I 100% agree with you on that. There's no doubt in anybody's mind. You see, biosimilars came with a bang. They got approval in US also now. India also, DCGI, there are more than 5 biosimilars which have been approved. But purpose of biosimilar entering was that it can be blindly given to anybody, which is not happening. Total cost to the patient is still very high, very high. So if that comes down to half level, or, you know, 1/3 of the level, then I would not hesitate. But if that does not happen, then obviously, because of, you know, the second slide of yours, largest trials, largest molecule, largest patient years, then that goes in favor of innovator.
Also in the COVID era, I would like to add that, you know, we came across, you know, certain things that, you know, with the vaccines we learned that, you know, there are things known as adjuvants in vaccines. So like that we have, you know, excipients in these drugs. You know, so what the excipient can do, and I think in the past, whatever episodes of problems we've had with biosimilars, it was linked to sometimes even the rubber which was used to make the stopper of those vials. You know, I mean, a lot of investigation went, then the company went back. I mean, you know, I wouldn't like to name them, but, you know.
Those actually are nothing to do. You see, the problem with not the drug, it's the ultimate approval.
Yes. Yeah. So, but we are injecting whatever is given to us in whatever packaging is given to us. So, you know, when you come across biosimilars, so again, there's an attempt at cost cutting, because, you know, that is what they want to do. They want to reduce the cost, maybe of manufacturing or whatever, but it really, you know, was a, you know, kind of a revelation that, you know, these factors can play an important role, you know, in causing inflammations, and we know of ADAs and anti-drug antibodies and all those things.
So let me ask, you see, for the sake of how many in the audience, or maybe Ajay included, me included, use biosimilars with as much confidence as innovator? Just show of hands that who are in favor of biosimilars and who are in favor of innovators. So I think, you know, by and large, it's a divided kind of house that people, you know, want the cost to come down definitely. And that's what you see, what I was saying was that if I inject today Eccentrics, the cost is much less than if I inject the other biosimilar. Cost to the patient I'm talking.
Right.
Ajay?
Yeah, so I know, Saurabh, it's a very difficult question what Dr. Lalit asked you, and sitting in this particular session to answer that which one you will choose, innovator for a VIP versus biosimilar for a non-VIP. But I think what he brought out was that if you calculate the overall cost in the end and look at the schemes which are being put forth by the company, it works out equally efficacious and cost effective in the long run. I want to bring out 2 points. One is interchangeability, and second is effectivity. One of your slides, you showed the effectivity of the molecule of biosimilar can vary from 26% to 212%, which is very interesting. When you compare the effectivity, you compare it with the innovator molecule, and innovator molecule is considered so almost 100% effective if we consider that. That means there is a batch-to-batch variability of the biosimilars of effectivity of the drug if certain batches are tested, and same ranibizumab by different companies can have different effectivity. The problem which we are facing in a lot of parts in the country is patient goes for the CGHS panel and they says, "Ye razumab le jao." Supposing some other drug gets approved, they say ki ranibizumab chahiye na, doesn't matter, you take another company's ranibizumab. So when we inject and the patient gets us a vial, we have to inject ranibizumab, it may be any company. So is that permissible? Do you follow it, or do you insist on a particular biosimilar if you ever use biosimilars?
Yeah, so I mean, so sometimes we can't just do anything about it, because if it's a panel patient and you know that particular, a different drug is there on the panel, approved or whatever, or available, then I don't think we can say no to the patient. We would have, and if it's an approved drug, of course, we'll have to give that.
So I think the answer to Ajay's your question is that I tell my patient that it is at your risk I am injecting.
Yes.
I will get it because I recently had one doctor lady who brought one biosimilar in a pouch by herself. So I said, at your risk I am injecting, but otherwise I am not very keen. So that you have to tell to the patient that why. You see, I agree. Today is in this era of generics, you cannot actually write. You have to write ranibizumab in bracket. You may write Accentrix or any brand, but that you have to talk to the patient.
Yeah, so I think it's important for as a take-home message that whenever you are interchanging between molecules, it's important to communicate to the patient that ranibizumab, if the patient earlier had an innovator molecule versus a biosimilar, there can be differences of efficacy, as well as what he brought out is batch-to-batch variation of excipient. There can be reactions which we have seen. Over the period of many years, we have seen that the innovator molecule has been standardized and the reactions are far less as compared to the biosimilars.
But Ajay, let me tell you, this interchangeability is still a dilemma. Interchangeability is still not allowed, I think. You can't substitute, suppose you are injecting, say, Rani eyes vis-a-vis Razumab vis-a-vis this, because it's not only the ranibizumab, but a lot of other things which may play a role in the ultimate outcome also. So even in the wider perspective, interchangeability is still a question mark. It's a question mark. So thanks, Saurabh, for bringing out this an ultimate message. I think should